Hi everyone, my case study presentation is on a patient whom I've been working with since I started externing at Ahava Medical Center. For confidentiality purposes, I will refer to him as Mr. Y. Mr. Y is a 51-year-old male who has a significant medical history. He presents with a medical history of seizure disorder and history of traumatic brain injury secondary to a motor vehicle accident in 1996, which resulted in damage on the left temporal lobe. He previously received intensive head trauma rehabilitation post the motor vehicle accident for 16 months. And 5 years ago, he had a hematoma resulting in memory impairments and development of obsessive compulsive disorder. His sister expressed concerns that he has difficulty recalling information, sequencing activities of daily life, and responding to questions with a delayed response. He currently lives at home with his family, and he has two aides that assist him with activities of daily life. Studies have shown that patients post-brain injury may demonstrate changes in behavior and personality, and these include self-centeredness, disinterest, quarrelsome, and socially inappropriate behavior. Mr. Y has actually displayed aggressive behavior during our sessions with his aides, and his sister had reported that prior to his TBI, his behavior was very different. He also presents with a profound hearing loss in both ears. However, he refuses to wear hearing aids. I have not seen him wear them once during our session. He is, though, able to understand by reading people's lips. However, processing information and responses are delayed. He uses minimal gestures and minimal verbal output. In individuals who have suffered from TBI, cognitive areas of memory, executive functioning, and processing speeds are greatly affected, as seen with Mr. Y, and his history of TBI has severely impacted his cognitive communication abilities, which has become the focal point of our therapy. He also shows impairment in memories, and studies have revealed individuals who have suffered from TBI also present with cognitive changes, specifically and significantly in slow thinking and difficulties with concentration and memory. Traumatic brain injury is a leading cause of disability in people under the age of 40, most commonly occurring in males aged 15 to 25 years. The following objective and tests were administered: a patient interview, receptive expressive language analysis, and informal cognitive communication evaluation. Expressively, his response and processing times were severely delayed. He constantly relied on lip reading as well as maximum volume or loud voice to understand, and he required multiple repetitions. Conversations with individuals post-TBI are difficult to follow since they are dependent upon the communication partner to maintain the flow of the conversation. He did identify common objects, object functions, and descriptors. However, he required maximum cueing and modeling from the clinician. Receptively, he answered yes or no questions using his head and hand gestures. Also with prompting, he did not follow 1 to 2 step directions independently, nor did he answer questions regarding temporal or time concept, safety, and problem solving, all of which are essential for living a more independent and functional life. In terms of his cognition, he is alert, aware, and awake in his environment. He attempts to answer clinicians' responses. However, his auditory processing and responses are severely delayed, as mentioned before. Deficits following commands, answering questions regarding listening comprehension to stories and sequencing, and auditory processing are present. Deficits in executive functioning is a hallmark impairment following TBI, and it affects planning, attention, and working memory, all of which are consistent with what Mr. Y presents with. Cognitive deficits in these areas, for example, may impair activities of daily living, social relationships, and active participation in the community. Studies also show that there is a significant relationship between the injury level and the degree of cognitive impairment. For Mr. Y, it was quite severe, and it doesn't matter how long ago the incident took place, these cognitive impairments affecting processing speed and executive function may still be present 10 years later. Mr. Y's motor vehicle accident was back in 1996, and it's been more than 10 years, and these symptoms are still present. It's important to mention that a recent instrumental exam has not been conducted. Mr. Y expressed concerns regarding his swallowing and eating. The last modified barium swallow study was several years ago, resulting in a diagnosis of oropharyngeal dysphagia. His sister reported that it does take quite a long time to swallow food, and previously he used chin tuck. However, he required constant verbal and visual reminders to implement strategies due to his memory deficit. Currently, his diet is a soft, mechanical, finely chopped diet with thickeners. He had his clinical swallow eval done at Kingsbrook Hospital, and the SLP there had recommended he continues with the original diet due to no history of pneumonia. Soft mechanical foods and nectar-thickened water are highly recommended due to presence of a delayed swallow trigger and decreased hyolaryngeal excursion. Mr. Y is a high-risk case due to the fact that he demonstrates a significant hold on the bolus of all consistencies. Since we are at an outpatient rehab setting and not a hospital setting, the facility does not have the appropriate and necessary equipments to do feeding and swallowing with Mr. Y. The SLP at Ahava, where I am currently, referred him out to Kingsbrook Hospital, where the clinical swallow eval was conducted. At Ahava, we focus more on his communication deficits, and we continue to make sure that Mr. Y eats his recommended food and is consistent with his diet. We also provide a lot of tactile stimulation and prompting to remind him and encourage him to swallow during sessions when his aide feeds him his medicine. The diagnosis is cognitive communication deficit secondary to traumatic brain injury, and the current problems are as listed. I've also included the G-code here. His long-term goal is the patient will demonstrate improvement in cognitive linguistic skills as well as receptive and expressive language skills for communication of wants, needs, and activities of daily life. The short-term goals are as listed. Due to the fact that Mr. Y hasn't been coming consistently for the past couple weeks, we haven't targeted all short-term goals, but I will run through them. Short-term goal 1, the patient will identify common objects in a field of 2 to 3 in 9 out of 10 opportunities, given maximum phonemic and visual prompts over 5 consecutive sessions. And these objects are objects that we believe will be functional in his everyday life, so articles of clothing and home appliances. The patient will identify common objects based on function in a field of 2 to 3 in 9 out of 10 opportunities, given maximum visual prompts over 5 consecutive sessions. These visual cues include photo cards. The patient will identify common sight words that are associated with pictures or objects presented to him in a field of 2 in 9 out of 10 opportunities, given maximum visual and tactile prompt over 5 consecutive sessions. Examples of associations with pictures or objects include hot for stove or sleep for bed. And again, photo cards are provided as prompts. The patient will answer simple WH questions presented to him visually and or auditorily in 9 out of 10 opportunities, given maximum phonemic cues over 5 consecutive sessions. Questions include what is your name, who is your sister, or even the functional uses of certain objects. The patient will follow simple 1 to 2 step directions presented orally and or auditorily by the clinician with maximum verbal or visual prompts over 5 consecutive sessions. I do believe that the goals are appropriate for Mr. Y, as they do target functional skills that he must improve upon. And the object he is required to label and answer about are common items that are found in his environment, such as at home. And the goals are truly intended to improve his cognitive communication abilities, which, as I've mentioned before, is the main focus of our therapy here at Ahava. And his sister, with whom he lives with, as well as his aides, have reported that Mr. Y has shown improvement in labeling objects at home, referring to things that he needs or he desires. And so that shows that he is generalizing the skills outside the therapy room. And due to his memory impairments, which are quite significant since his TBI, we have implemented compensatory strategies as well. Mr. Y has a memory book that contains images of family members and personal information. And this is reviewed during sessions, also in the form of WH questions. Memory impairment, according to a study, is one of the most common cognitive impairments post-TBI, and often the first function to be disturbed and the last to be restored. And strong evidence reveals the use of external memory aids in compensating for the memory impairments. In Mr. Y's case, we utilize external memory compensation such as his memory book. And the frequency of his treatment is twice a week with a reevaluation every 30 days as necessary. In terms of the treatment approach and progress, so we implement a use of multimodal communication system. During our sessions, we implement compensatory strategies to communicate with him. We mainly communicate with Mr. Y using a whiteboard, which we found to be an ideal tool and an alternative communication system. So questions and comments during activities are generally written on the board, which he responds to, and we found that raising our voice wasn't very effective. We also train the family and caregivers to communicate effectively with Mr. Y using the support and strategies. We suggested that his aides and sister, whom he lives with, also utilize a whiteboard, and they have. Mr. Y's sister has reported that it's made it easier to communicate with his brother, and he has become less frustrated because he is able to express his needs and wants through this medium. We also suggested that in the home, Mr. Y's sister provides tactile stimulation while writing swallow on the board to remind him to swallow, where she would touch his neck or hers, since he tends to hold the bolus in, which is dangerous, of course, when it comes to swallowing. And AAC, as we all know, refers to various modalities utilized to support expressive communication needs of individuals with deficits in speech. It has been greatly applied to brain-injured population through non-technological methods, which are gestures and communication tablets, and depending on the needs, desires, and the severity of their diagnosis, low-tech and high-tech devices are available. And so just to recap, compensatory strategy training is implemented in our therapy sessions, and that includes external strategies such as the memory aid, the memory notebook. We also believe that through this form of AAC, and through the implementation of our treatment approaches, we aim to optimize Mr. Y's communication and hopefully have him achieve the greatest possible quality of life. And the attainment of the goal, of course, is dependent upon the patient's motivation and ability to express what he wants to say during sessions. And currently, we have, according to our data, have seen progress, and we also see a lot of motivation from his end. Thank you.